Mr. C is a 60-year-old gentleman living with type 2 diabetes mellitus for the past 10 years. Knowing that he has this condition, he decided to treat himself with metformin he bought from different pharmacies. On one fine day, while he was purchasing metformin from the usual pharmacy, he was advised by the pharmacist to do some blood tests. So, he did. The results came back shocking, as he was found to have renal impairment. Upon reviewing his blood results, his creatinine level was at 350 micromoles per liter, and his HbA1c level was at 9%, both of which were significantly elevated. He was also found to be anemic, as his Hb level was 9.5 grams per deciliter. With his creatinine level, Mr. C's estimated glomerular filtration rate, eGFR, was 15.4 milliliters per minute, indicating a stage 4 chronic kidney disease. Looking at Mr. C's condition, a management plan must be constructed. 3 types of oral anti-diabetic agents came to mind, namely dipeptidyl peptidase 4 inhibitor, DPP-4I, short-acting sulfonylurea, and insulin. DPP-4I, such as sitagliptin, inactivates incretin hormones such as glucagon-like peptide 1 and reduces HbA1c levels by 0.5 to 0.8%. Thus, is proven safe to use with dose adjustment. Short-acting sulfonylurea, such as glipizide on the other hand, acts by increasing insulin release from the pancreas and must be used with caution and at reduced dose. If all else fails, insulin can be given. Other oral anti-diabetic agents are not used as it may cause harm to the patient. This includes GLP-1 analog, as it is excreted by the kidney, SGL2, as it is not approved to be used in patients with low eGFR, metformin, as it can cause lactic acidosis, and TZD, because it causes fluid retention. Apart from Mr. C's diabetes, his anemia has to be treated. The common cause of anemia in CKD is usually related to iron deficiency and erythropoietin deficiency. Hence, an iron study has to be done in order to identify the cause and treat it accordingly. If the anemia persists, Mr. C can be treated with EPO injection.